All right, I think we are going to go ahead and get started so we can have enough time to hear your talk, Jim. So welcome everyone to our second seminar in this Global Health Seminar Series for this spring. And we are really focusing on COVID-19 for, all the good reasons. I guess it's a relevant time for us to be talking about various topics. And that's what we've done actually since last fall. So for those of you who are joining us for the first time in this seminar, we hold this once a month, every last Thursday of the month, both spring and fall. So this is a year-long seminar, I should say, open to students, both graduate and undergraduate, faculty, staff across campus, and any other interested person who would like to hear about interesting topics in global health. So again, we have all the speakers lined up for this spring. Next month, which is March, in the last Thursday, we'll have a talk on COVID-19 and health policy. And then in April, we'll have our students present some of their research work in global health. Some of it might be about COVID and other topics might be different. Again, I'm putting that out just so you can come back. We have a lot of interesting topics coming on. But today we have the honor to hear our guest speaker, Dr. Jim Thomas, who is going to speak to us about the ethics of COVID-19. So I'll tell you a little bit about Dr. Jim Thomas before he goes on to speak with us. Dr. Jim Thomas is an associate professor in the Department of Epidemiology at UNC, University of North Carolina, Chapel Hill. And he's also the director of Measure program at Carolina Population Center. So a little bit more about Dr. Thomas. His work in public health spans more than 35 years and around 35 countries. I guess it's a year each country. His principal interests are in social forces, underlying epidemics, ethical concerns in digital surveillance, and the ethical practice of public health in a pandemic. And in addition to his many scholarly articles, he was an editor and author of a textbook on epidemiologic methods in the study of infectious diseases, and principal author of the initial American Public Health Association's Code of Ethics. And so as director of the Measure program, Dr. Thomas is leading a global team that is advancing the capacity of developing countries to monitor their epidemics. And in the context of COVID-19, Dr. Thomas is advising government planning groups, speaking and writing on pandemic ethics. And as such, he has also created an online pandemic ethics dashboard, which we definitely have a link and we can share that for you to check it out. And this is a great resource for policymakers. So we are truly excited to have an expert on ethics and who has really thought about these issues for a very long time. And so without any further ado, Dr. Thomas, you're welcome. Please take the floor. And just for the audience, please, if we would hold our questions to the end, Dr. Thomas will speak and then we'll have a period of maybe 10, 15 minutes of Q&A. And I encourage you to use the chat box, drop your questions there. And then once we get to the Q&A, we'll take one by one of those. Thank you very much. And Dr. Thomas, go ahead and share.
Thank you, Juliet. We are to end by 5, is that right?
Correct.
So, okay, just so I judge well how I use my time. So let me tell you how I got into ethics as an epidemiologist very briefly. I was doing some epidemiologic research in rural North Carolina around sexually transmitted diseases. And in that work, I ran into some quite striking racism that was troubling to me. And I wanted to write about it in public health literature. I wanted to appeal to an epidemiological or public health language of ethics, but it didn't exist. So there was lots on medical ethics, but not on public health. That's how I got into having an interest in ethics in public health and eventually writing the code of ethics. Once I wrote that code, it gained some attention, and I was asked to be an ethics advisor to the director of the Centers for Disease Control. It was at the time when we were anticipating a pandemic of H1N1 influenza. And as we were anticipating that pandemic, we were thinking through what could we anticipate as being the ethical issues. I spent some time working with CDC on those questions, also some time with WHO. And when COVID happened, see, the H1N1 pandemic didn't really happen as we expected it, but when COVID happened, then all of that background kind of came back to the fore, and I began talking a lot about pandemic ethics, and that's what I'm going to be talking with you about. So let me share my screen, and as I do that, let me ask you to interrupt me. I am hoping that as we go through this, you will see something that maybe you don't understand, and you can say, hey, wait a minute, tell me more about that. Or if you have a question, then please do ask it. I cannot see the chat as I present, and so you're going to have to speak up if you want to interrupt. But I maybe Juliet, if you see the chat and somebody says something, you can encourage them to say something.
Yeah, I'll keep an eye on the chat for you.
Okay. So first, let's just see where we are. These are statistics that are up to date. I clipped these off of the WHO site just hours ago. And you can, this is counting on the right here. These are the weekly numbers of cases. And you can see that we have climbed a mountain and we're coming back down the other side. This last bar is incomplete because they're waiting for the week to finish. But if things that you might notice in looking at this is, if you just look at this bar here, the most recent bar, you can see that most of the bar is green and yellow. Probably 3/4 of it, if not more, which is over here in the Americas and Europe. Now, there's not a lot going on in Africa, but that could be, see that just a little tiny sliver of dark blue there. It's possible that's because many of those countries just don't have the mechanism to count the cases. There could be a lot of under-reporting in some of these places. But let's look at this now in terms of a map. And this is, we're now looking at deaths, we're not looking at cases. When you look at the deaths, again, you can see there's North America. Latin America has a high number. This is rates now. These are deaths per million. So we're adjusting for population size. If we're going to look at Africa, well, South Africa has the most. And then we've got, this is Russia over here in Europe, Scandinavia. And I don't know why that's Iceland, that's Greenland, isn't it? I don't know why it's that color. That we don't have a legend here to really tell us, but one can imagine that the darker colors are higher rates. So we're going to see a couple of rates. Here is the death rate in the US, 1,385 deaths per million people. Now, for comparison, let's look over at China over here, where the epidemic began, and see what their death rate has been. Just three deaths per million population. Quite a striking difference. Keep this question in your mind as to why that is. I'm hoping that you will bring forward some questions or some speculation about why there is such a difference between these different rates. If you look at America, and we saw this very high rate, well, how does that then rank in terms of the mass casualty events that we have had in the United States? These are the top 5 mass casualty events in the history of our nation. Got World War I and World War II, and now COVID at 505,000 is above both of those. and the American Civil War, 655, the 1918 pandemic, 675. This is just as of, if you look at this asterisk, just as of yesterday. This number is still rising, and it's conceivable that it will go past the Civil War and become the second highest number. It could, depending how things go still much further. It could become number one. So what makes this an ethical issue? Well, because human lives are involved and the dignity of those lives, the relationships between people involve the ethical implications when for example, an elderly person is in a nursing home and they have a caregiver who is a grandchild or a child who lives outside the nursing home. When the older person is dying, nobody can visit in some cases. And that's just really, really shocking and hard for people not to be able to be in touch with each other as they die. So there are ethical issues in there. And wherever there is power involved, you're going to find ethical issues. The power in question here is the power to do something about it, the power to prevent, the power to fund the development of vaccines, the power to stop people from gathering. That's another reason why it is ethical. And then the third is that when there is a consensus on right actions to take, then we have something to go on to say this is what's ethical and this is what's not. And we have that. So we have three documents here that I'm presenting. The two on the outside are both from WHO. On the left, we've got one that deals with infectious disease outbreaks, and that's fairly recent. It came out in 2016. The one on the right is specific to pandemic flu. That came out in 2007. And then in the middle, you've got the Public Health Code of Ethics, which also touches on public health actions in the midst of a pandemic. These were all brought together into the pandemic ethics dashboard that I created. And I'm going to show you very briefly how this dashboard works, and we'll be referring to it, information that comes from it as we go through this presentation. So you've got two ways that you can navigate this. First, the small print. We can look at before the pandemic and how we need to prepare, what we do during the pandemic, once we begin to reopen, which is the phase that we're pretty much in right now. And then after it's all done, there's an aftermath and what needs to be done to reflect on how the pandemic went. So that's one way that you can navigate through here. The other is consider whose perspective you want as you look at the ethical issues. Are you the government that is putting in effect these mandates, or are you a hospital, or are you a researcher? So if we look at the government over here, if we were to click on that, we would land on this page. And it would list the kinds of ethical issues that need to be addressed in a pandemic. And we might select this one that relates to engaging with stakeholders. If we click on that, we end up here, and we have a number of factors about talking with stakeholders. This, in internet terms, is called an accordion. If you were to click on this, all of this would collapse underneath it, and you would see a bunch of other issues like this that are listed below. But I'm just going to highlight right now just one example of a quote from the CDC Ethics in Pandemic Flu document. And they say that public engagement and involvement are essential to build public will and trust, and should be evidenced throughout the planning and response process. And I'm going to focus on this word trust right here, because that's what public health really depends on to do anything to control an epidemic, to address an epidemic, because the US is not an authoritarian government. It can be, but it prides itself on not being authoritarian. And so it has to work with moral persuasion to convince people that this is the right thing to do. And to have that moral persuasion, you've got to have trust in that government. So that was my very quick tour of how the pandemic ethics dashboard works. And now we're going to go into more of the substance of what we're addressing in this pandemic and what ethics looks like. So I've got three elements here that we often, well, the first two are what we often hear as priorities for control of the pandemic: the efficacy and the equity. I'm adding a third: process. And rather than explain them here, we're just going to walk through them and you will see what these are. So in talking about the effectiveness relates in part to the biology of the organism. And we want to be effective in controlling it. So if we have the power, remember that term, if we exercise our power well, then we're going to be more effective in controlling the pandemic. But that's very tricky on the front end because it's a novel organism. We don't know it well. And because we don't know it well, we have a little bit of background. These are other coronaviruses that we've had experience with. But the one that we're dealing with now is called SARS-CoV-2. So it would be added below here as yet another. And each of them is a little bit different in how they present and how they act. When you don't know, you're going to make mistakes. And when you make mistakes, you're going to have to make some path corrections. You're going to have to say, oops, I'm sorry, that was wrong. So the WHO Ethics in Pandemic Flu says that preparedness plans should be flexible enough to allow for timely adaptation as new evidence about the nature of the disease arises. As an example of that, we've got the CDC, which early on said, don't wear masks. Then later on, they said, nope, never mind, wear masks. This flyer with not my highlighter here, this is how I clipped it off the web, highlights that at the very front end of the pandemic, CDC was trying to dissuade people from using surgical masks. And yet now we're told to wear them, oftentimes to wear 2 masks. This is an example of how they adapted to new knowledge and have said publicly, we were wrong and we've made corrections. Another question about effectiveness is the infectivity of the organism, which we figured out slowly over time. So let's take a look at this somewhat complicated graph here and we're going to look at here at this axis first. This is reporting the infectiousness. These numbers mean, let's just take these two. The number 2 means that if you have a common cold, then on average, a person with a common cold is going to transmit that cold to 2 other people. That's where the 2 comes in. This is the infectious, the R1 or the R naught, R sub 0 here. That is the reproductive rate is the term it's used. Chickenpox, look how high it is up here. On average, a person with chickenpox is going to infect 8 to 9 people. This orange box is where science is saying COVID-19 lies. It depending on circumstances, it can be more or less infectious. And this vertical axis here is how dangerous it is, the percent who die. So we have bird flu with a very high case fatality here. This is based on a small number of cases. This is transmission from usually duck flocks to humans, often around Vietnam. And the people who get infected that way many of them have died. Here's Ebola. Now, Spanish flu is the 1918 influenza. So COVID-19 is right around that same case fatality. And so we've got this box here with a relatively high infectious rate. Notice that it goes well beyond what the Spanish flu was. It's higher than swine flu or seasonal flu or rotavirus. It can even be considered higher than the common cold. So when something is highly infectious like that and dangerous, it's going to spread quickly and kill quickly. So it requires quick action. Ethically, what we see in the WHO ethics in a pandemic flu, even when access to treatment or prophylaxis is limited, the public is entitled to timely and accurate information. When something is known, it needs to be shared. There are other ethical elements that would address transparency as well. Being transparent about what you know. Well, there it is right there on top. Timely, transparent, and accurate information. So let's take a little closer look at quick action and why it's important. You've got two graphs here, and I'm going to focus on the one on the right. On the left, we're dealing with states. On the right, we're dealing with cities, New York City and the San Francisco Bay Area. This is where we're going to be looking for now. We're in March of 2020, and this is when the pandemic was just beginning. Very early in that time, on the 16th, the San Francisco Bay Area put in place a shelter in place where I'm sure you remember this, when people were to stay at home and not go about town. And after that, there was a very slow rise in cases in San Francisco. New York City did nothing at that time. They waited until around, looks like the 22nd. And by that time, the epidemic had taken off because of its infectivity. It had infected a lot of people, and it basically set up house in New York City so that any kind of controls at that time, like a stay-at-home that New York put in place, was going to be less effective because it was already out and being transmitted. And then you recall the dire situation that New York landed in just months later, where the morgues couldn't keep up with the dead bodies, and they had big trucks that were freezers outside the morgues to hold the overflow of dead bodies. So quick action makes a big difference. This relates to the efficacy of how we control the pandemic. I'm going to pause because I've been hearing my voice too much, and I'm going to back up one. And I want to ask if there are any questions about what you have heard so far.
I have a question.
Yes.
Okay, so going back to when we were comparing the deaths between US and China,
Yes.
and deaths per million, do you think that the difference in the deaths between US and China could be a result of like the type of government that they have in place, such as like we have a more democratic, so we're all about human ethics and, you know, giving them their rights, whereas China's more of like a communist republic type government. So do you think that that would have an effect on the deaths per million?
I do. It's not so much that they're a communist, but they're more authoritarian. And their current president in particular has really ratcheted that up. So there are some advantages. You know, in America, we're quick to look down on authoritarianism and authoritarian abuses, and there's much to look down on. But there's also some things that authoritarian governments can do very quickly and very effectively. And controlling a pandemic, when they've got the ability to say something and to make it so and to enforce it, then it can begin to control the transmission quite quickly. They have put in quarantine cities of millions of people, which is quite a feat. But now another factor, I've talked about authoritarianism. Another factor of the Chinese population is that the Chinese culture is more a culture of honoring elders and honoring superiors. In America, we love to tear each other down if anybody tries to present themselves as being higher than anyone else. In Chinese society, it's and elsewhere too. I would say for much of Africa, and I'm less certain about Latin America. I know this about Mexico, so probably other areas of Latin America as well. There is a greater deference given to people in authority, and I know in particular around China, and if any of you is Chinese, please correct me on this. But I think that the Chinese identity as a person comes more from being part of a people group, like a family, like an extended family. Their identity is more tied to that group than it is in America, where we pride ourselves on being individuals and able to do whatever we want and not care about the group.
Okay, thank you.
There's a hand raised.
Yeah.
Dr. Whalen, I think, had a hand raised as well.
Yes.
Yeah, thanks, Juliet. Jim, thanks for the talk so far. I had a question. You know, it's one of perspective, and those people who know me will recognize what I'm going to say. That in the year of the COVID pandemic, 2020, there were more deaths due to tuberculosis than COVID-19. There were 700,000 deaths due to HIV in 2020 as a result of HIV disease, even when treated.
Yeah.
And there were 400,000 plus deaths in children due to malaria.
Yeah.
During the same time. Now, those diseases have been around for a long time, and these deaths have been occurring year after year after year. And somehow along comes a pandemic, and all of those well, not all of them, but definitely TB and HIV remain pandemics. I don't understand the ethics of the response to COVID in the face of these other pandemics.
You make a good point. I did, when I was doing my dissertation for my PhD in epidemiology, I wanted to work with the disease that was the cause of the most deaths worldwide. And so my research was on diarrheal disease, which is not a very sexy topic, but in terms of worldwide impact, it has a huge impact. And so what we see is, I think, a habituation to a certain pattern of disease. And I don't want to call it an acceptance, but a normalization that would allow a tuberculosis or a malaria to just kind of fester on. And there's also some excuses made that to address tuberculosis requires the creation of huge systems in resource poor areas. I cannot really provide you with an ethical support of that argument. I'm not of that mind. I think the reason that COVID has the impact that it does, well, so one can say is it's just the suddenness that does this, that gets our attention. But a more cynical person might say that it's gotten the attention because, as I showed very well, it might even be the previous slide. As you can see here, the countries affected are the wealthy countries, the ones that are the most affected. So now you've pulled the cynic out of me. There you go. Do you have a follow-up comment?
No, I agree with a lot of what you said. And yes, I do worry that some of the response is the result of wealthy countries feeling under attack by something new and different and something that they've been taught to be afraid of. My work is in Africa with Juliet, and we've tested and screened for COVID and don't see very much of it. So
Right.
I don't know whether that means the epidemic hasn't fully hit yet, or whether there's some other factors that we don't understand yet.
Right.
That seems to be protecting and mitigating the epidemic there.
Right.
Well,
that's part of what happened with HIV. If we realize that HIV emerged out of the Democratic Republic of the Congo, and but in the DRC, the transmission and the prevalence of HIV is not nearly what it became in Southern Africa.
Yeah.
And one of the reasons being that transportation in the DRC is very difficult. You can't move around as much, and so that means that the organism can't move around as much. But in South Africa, much greater infrastructure, people do move around, and great transmission occurred. So whether there's a corollary there with COVID, I don't know yet.
Yeah, I believe that we needed to respond to COVID for sure. But what seems to be missing from the WHO is, and maybe the CDC to some extent, is what I would call a global perspective. Whenever a pandemic occurs, we have to sort of see it in the context of everything else, all of the other major problems that are going on, and recognize we acknowledge the problems of TB, but we're going to continue our efforts to control TB while we mobilize against COVID-19 and so on and so forth. And I haven't heard that ever from anybody, yet I think it's an important ethical statement to make.
Right, I agree. It's not an either or; it's a both and. But yeah. we're clearly falling short on some very long-term issues, and we can't just let COVID steamroll everything else that is happening.
Yeah.
Jim, there was one more hand up, so
yes.
If the person asks the question, I can't tell the name. Please, the person who has the hand up, go ahead and.
Thanks. Sorry about that. So we see a lot of reports on the death rate. We see a lot of reports on the case number, and we see a lot of reports on just the raw death number. Do you have any idea about the DALY amount, the DALY, disability adjusted life years?
Well, so I'm going to wing it here, but I'm going to guess that if we can call them DALYs, what's that? Daily adjusted life years or disability adjusted life years. Mm-hmm. That we're just now beginning to figure out the disabilities in the younger ages. There are some emerging chronic issues, but we don't know just yet. I don't know just yet how debilitating those are. We do, of course, know the death rate, and we know that the deaths are much more common in older people. So the DALYs for diarrhea, which I was talking about much earlier, are going to be high because that hits very young children. So they lose a lot of potential life. But in COVID, it's going to be affecting people 60 plus, 65 plus, and potential life remaining for them is much less. So that what would affect the DALYs is just the sheer number of cases or the number of deaths, which, as you saw on that slide reporting in America, you can see that in terms of these major events that COVID-19 is rising towards the top, the one causing the most deaths. Okay, so with if there's no follow-up question, I'm gonna rush back to where we were.
Right.
And all these different slides, there's no easy way to do that. All right, so now we're down to these ethics of equity. So let's take a look at the national level equity before we look at the individual level of equity. And this is an article that came out of the Washington Post on just January 18th, not too long ago. WHO chief warns of a catastrophic moral failure as the rich countries dominate the vaccine supplies. So who has cornered the market on the vaccines? Well, we've got Canada at the top. Surprisingly, those sweet, kind Canadians have been effective at buying a lot of the vaccines, and then America is right there close behind them. But let's look at how we're supposed to read this chart. This along the bottom here is the number of vaccines required to vaccinate the whole population. And if it's not entirely clear to me whether this is taking into account that sometimes you need 2 vaccinations, or Pfizer or Moderna at least. So let's just give them the benefit of the doubt and say, well, the goal is 2. Well, this now, once you get to 3, you have bought more than you need. Now, maybe you could argue that you have more than you need because some of it's going to go stale before you use it. You're not doing a good job if that's the case, but let's say that's true. Now you're really grossly over the number at 4, over the number that you need for your population. But up here, this is the catastrophic moral failure that the WHO is talking about, where we have bought so many vaccines that it's having an effect on these other countries. So let's take another look at this. This is from our World in Data. And this is a map that is showing the share of the population fully vaccinated against COVID-19 as of February 24th, which is what, yesterday? Yeah, yesterday. You can see that in the US, which is, I think, the darkest green on this map, Israel is probably a darker green because they're really high. They're like up here at 60% somewhere. So they're quite the exception. But America is between 10 and 30%. I think the last I heard was like 12% and rising, of course. But South Africa, we saw a little while back, had a high rate of COVID, but their rate of vaccination is down here less than 0.1. So you can see that the European countries have been quite effective in buying up the vaccine, leaving other countries behind. Now, just recently, this is again a February 24th news article out at the Post. First vaccine doses distributed by COVAX, which is a WHO program to distribute vaccines to low and middle income countries. Distributed by COVAX, they landed in West Africa, the nation of Ghana. And so this is the load coming out of the plane. So there is a mechanism for distributing these. Under the previous administration, we had opted out of COVAX. We were not participating. And with the new administration, we are participating. So we're beginning to change our ways in that regard. But even so, there is a long distance to go to achieve equity in the distribution to low and middle income countries. And a point to remember here is if you just think about the variants that are arising that are causing trouble for Pfizer and Moderna. They came from Brazil and South Africa. The South African one in particular has been slippery, and Moderna is now in the process of developing a booster that would take care of that particular variant. But when you have a sizable population that is not immune, and they are transmitting amongst each other, that's an opportunity for the virus to mutate and to create new variants that then can be transmitted worldwide. So if you're going to, let's go back to effectiveness. If you're going to be effective, even in America or Europe, in controlling disease transmission, then you need to also be helping with the vaccination of other countries where other variants could arise. So even if you're just talking about effectiveness, not equity, it's important to think globally and not just about yourself. And then individually, and who gets the vaccine? Well, there are guidances in how to make these determinations. Here we have the CDC saying that the distribution of goods should be guided by criteria specified well in advance. And there are in that CDC guidance, and when they say this is how you should go about making this decision of how you allocate, they emphasize that you be clear about your goal. What is your goal in vaccination? Is it to minimize transmission? If so, then you're going to prioritize people in congregate living, which is going to include nursing homes. It's also going to include prisons. Maybe your interest is in preserving the social infrastructure. Well, then your priority groups are going to be clinical personnel and law enforcement. Perhaps your goal is to minimize deaths. Well, now your priority group is the elderly. We talked about this just a few minutes ago about how the risk of death from infection amongst the elderly is 100 times what it is amongst those below 20. And then you might prioritize equity. And if that's your primary concern, then you would prioritize racial and ethnic minorities, and perhaps in some rural areas because they often get neglected. In the case of the US, we have often run first to the clinical personnel and then to those most likely to die. The phases that the CDC has recommended are kind of mixing these different goals. There's no single goal. They're kind of going through phases of goals. So again, this was the first phase. Elderly was the second phase, and we're moving now to I don't want to say racial and ethnic minorities, but they are people more likely to become infected, who incidentally are often racial and ethnic minorities because they can be in lines of work that put them at high risk of exposure. So here we are looking again at our world in data, and you can see that different countries have taken different approaches to how they are making those priorities. If we look at this green one, they're starting with those who are most vulnerable. This doesn't tell us whether it means vulnerable to infection or vulnerable to death. Then we don't have any that are blue. We've got a couple that are orange that are focusing on one group. I just mentioned to you that in the US, we started with a couple of groups. Well, actually, look at that. It made me, it's challenging me. Maybe if we say it was the clinically available to one of the following key, I guess I have to read this a little more closely. This is the 1, 2, all that they're talking about. 1, 2, and all. Seems like it. So even in their number 1, they're including a variety: key workers, clinically vulnerable, and elderly. I would say that we actually began with the clinical and then we moved to the key workers and the elderly. So I might draw this a little bit differently. But the point here is that there's no universal right. Each country comes up with their own approach. And that brings me to my last point of these processes of ethics, which is that ethics isn't just finding the right answer or the right thing to do. It is most often about having a good process that people can agree to make a decision. And those decisions will be different in Saudi Arabia than they will be in Canada because of their culture, because of their government, because of their options. So you can have different ethical approaches. I'm going to go through this faster than I intended. In fact, I might even just skip it, where I differentiate between medical and public health ethics, because I want to leave time for questions. And I'm just going to point out that the guidance from the APHA Code of Ethics is to establish formal structures for making those processes, those decisions. And those decisions include these factors of inclusiveness, impartiality, transparency, reasonableness, and responsiveness. That's what is considered a fair procedure for making a decision about who should get vaccinated first. And in my case here at UNC, there is a campus and community advisory committee addressing questions of when to bring students back to campus, when to open bars. We have this group that is inclusive, that is transparent. It's transparent because it's on Zoom and anybody can attend, that is making decisions for the community on these questions. I'm not gonna talk about this either. I could talk at some length about these, but I'm more interested in hearing from you. I want to leave time for that. And these are a couple of websites where you can find the Pandemic Ethics Dashboard. And if you want to learn more about my work, you can visit that website. So I am going to stop sharing and see what kinds of questions you have or comments. Okay, then I'm going to ask you a question. You ready? So you're at the University of Georgia. How well has that campus done in your view of making decisions ethically that affect you as it pertains to COVID? Now it's possible that, because all I see is names, it's possible that you've all gone for a cup of coffee, but I don't think so. I think you're there.
I'll answer.
Thank you.
Okay, I think UGA has done like a really great job of controlling it the best that they can. There are some things that are just out of the reach of what the university can do. You know, like people are still gonna go downtown, they're gonna have parties, they're gonna meet new people, you know what I mean? There's not much that they can do outside the scope of classes, but as far as my classes have been, I think they've done very well of limiting how fast it's spreading here.
So you're talking about the effectiveness, which is legit.
Yes.
What about, let's jump over the equity. Let's jump to the processes. And I don't mean to pick on you. Others can answer. But has the campus had transparent processes in making these decisions, or is it done behind closed doors?
I actually am not sure about that. I'd like to say that there is a lot of inclusiveness as far as letting students have a say in what happens, what goes on, as far as, because it is their education, it is our education that we are getting, you know, and I've had multiple teachers reach out, you know, like we can always contact them if we think that, you know, being in person is better for our learning, and but also in a very safe manner.
Okay. So thank you.
So Jim, this is Chris Whalen.
Yes.
Yeah, I'm not 100% up to speed with all of the process that UGA has followed, but there has been a committee that has been informing the university president that tends to be, or tries to be, data, evidence driven. I think there are at least two other active committees. One that kind of comprises deans of the various schools, and the other that comprises more of a kind of a medical, a broader medical public health group of people. And as part of the response, I think everybody on the call here knows what the dog check is. It's a daily email that you get asking you about symptoms, and if you have the symptoms, they ask you not to come to school.
When you say dog, it's because you're the Bulldogs, is that right?
That's right. That's right. Not the dogs get COVID.
Well, they do. There's evidence.
They do, yeah. But I think from my asking students in my class, do they use that? They all say yes, and it comes on. It comes to anyone. I think it comes to everybody. And if you feel sick, it actually gives instructions as to what to do to seek care as a student, or if you don't know what to do, or if you've been exposed, what to do. So there's that information has been freely available from, I don't remember when the dog check started, probably sometime during the summer. So those are the processes that I know about.
So you've touched on the processes and you've touched on effectiveness. Like when somebody's infected, these are the steps they should go through so they don't transmit to somebody else. Let's now go to the question of equity. And let me ask if there have been any concerns raised by the housekeeping staff on campus, because they are often people of color. And have they raised any concerns?
I'm not aware. I do believe that they have representation on some of these committees, or whoever the boss is would have representation on one of these committees.
Okay. We eventually included housekeeping staff on a couple of our committees, but that was after there was some complaints and actually frank expression of distrust of how the university was handling things. There was a very prominent in the news event at UNC here where we brought our students back, and then there was this huge outbreak, many outbreaks actually, and then we, like 6 days later, sent everybody back home. We got a lot of mud on our face for that. And the chancellor got mud on his face because days before, he had received a letter from the county that we are in is called Orange County. He had gotten a letter from the Orange County Health Department saying, these are my words, "We've been in talks, you and we have been in talks, but we don't feel like you're listening. We do not think that you should be bringing students back to campus. Now, we can't force you to stop, but we don't think you should be doing it." And the chancellor kept that letter to himself and brought the students back. And we had this big, conflagration. So that really undermined the trust of a lot of people on campus in the steps that the chancellor was taking. And it was after that this committee, I showed you that slide of the Zoom screen. It was after that this committee was formed that included people from a wide variety of corners of the campus. How about your state? How is your state doing? I don't know the name of your governor. What's the name of your governor?
Governor Kemp.
Kemp, okay. So how is the state doing in being, let's just stick with equity. How are they doing with equity?
I think there's, maybe I shouldn't be speaking, but I from what I know and have heard, and it's very superficial, very much filtered through the media, the equity issues that I have recently heard about is distribution of the vaccine.
Mm.
And there are areas in southwestern Georgia where there are just not very many vaccinations happening.
Yeah,
and he went down there and tried to kind of campaign for wider vaccination. So
my wife is a physician and has a role working for the state. She's kind of seconded to the state to address health amongst migrant population. We have a lot, tens of thousands of migrant workers in this state who work in the fields, harvesting sweet potatoes, working in Christmas tree farms, and they live in camps. So it's a congregate living. And they work together, of course. Everything is all very local there. And if any one of them gets sick or gets infected, there's no place for that person to go to separate themselves. She's been working to get some sort of isolation facilities, even if it's just FEMA trailers or getting a hotel in town designated for people who are infected, but has been unable to do that. The state just won't do it. And what that means is that when one person gets sick, well, they virtually all get sick. And there are some equity issues there. Okay, any last questions? Because the clock is ticking.
Jim,
I have a question, actually.
okay.
Yes.
I wanted to ask, go ahead, please.
Anne-Marie?
So this had to do with a graphic that you showed earlier in the presentation. So in regards to vaccine distribution worldwide, do you think that an argument can be made for the countries that were on the graphic is showing for buying up the majority of the vaccines that are being rolled out? I could be interpreting that wrong, because I just remember you said there was more cases in like the US and UK. So is it an issue of some countries are being completely neglected and some are buying up way more than they need? Or could you just elaborate on that?
Yeah, you make a very good point. And as I was showing that map, I was having that very thought that if I were in Kenya and wanting to protect myself from the rest of the world, then I would be very interested in seeing America, which is so out of control, get under control. Because if there's a country where variants can develop, it's here, because there's so many cases and so much transmission. So you make a very good point that it's for the global perspective, it's really important that the countries that have the most cases get things under control. And there's a large amount of overlap in vaccine availability. Now, that doesn't address the hoarding. There are countries, Canada and US included, that have signed up for far more than they need. So that issue remains, but your point is well taken.
Thank you.
Hey, Jim, I wanted to ask a quick question or comment, ask you to make a comment about the developing country settings where the ethics of quick action may be compromised by the sheer lack of resources. What has been your experience?
So this gets to this notion of power, and where you have power to act, you have responsibility to use that power. But if you don't have those resources, then you're lacking that power to take that action. And I think that's one of the reasons why we need to treat this globally and look to those nations that do have the ability. Let's take, half of what Canada and the US has in its overstocking, and use it for those countries that are less able to act quickly. Oh, and I had another point that was just running away from me. It's gone. Sorry.
Next time.
Yeah.
Yeah, no, that makes sense. All right, looks like we have come to the end of our hour, and there being no more questions or comments, I would like to thank Dr. Thomas, and please join me in thanking him for giving us such an excellent talk. I'm sending a hand clap to you.
Thank you.
And saying thank you so much for sparing time to come and talk with us about this very important topic of ethics and COVID-19.
And I want to thank you for the questions that you raised. You raised your thinking. You're thinking in the right directions, all of you. Those questions that you raised were all very good.
So thank you all for joining this talk today, and we hope to see you at the end of March when we talk about COVID and the health policies related to that. Thank you.
Thank you all. Bye-bye.
Bye.